Everybody. My name is Katie Giza. I'm happy to have you guys here. I'm the Continuum of Care Coordinator with the Detroit CoC. CoC is the term or the acronym that we use to abbreviate for Continuum of Care, and we'll talk more about what a Continuum of Care is today. But very happy to have you guys here. We've got a lot of good content for you guys today, so I'm going to go ahead and get us started. As folks join, they can just feel free to settle in, but we're happy to have you guys. And so the purpose of today's session really is we want to help folks learn a number of different things. We want to try to explain how Detroit is responding to homelessness, what services and resources are available to people who are experiencing homelessness, how those people who are experiencing homelessness can access services, and then also how you or your organization can partner with the Detroit CoC in these efforts. And so to achieve these things, our agenda for today, we're going to talk about these a various number of things that are listed on the screen. So we're going to first just try to explain what a continuum of care is, why it's called that, how it functions, and then we're going to zoom in to the Detroit Continuum of Care. Then we're going to talk about a number of logistics for persons experiencing homelessness, how they can address concerns with services that they've received, and then how they can access the system and receive supports. And that's what we call that process of accessing the system, coordinated entry. And so then we're also going to talk about the collection and use of homeless data in Detroit. Then we're going to end it talking about how you can get involved. And then we'll have some time, hopefully at the end, if we can get through everything, for a Q&A portion. So with that, we're going to go ahead and introduce ourselves, and then we're going to dive in. So as I said, my name is Katie Giza. I'm the Continuum of Care Coordinator. I work for the Homeless Action Network of Detroit. We've also got folks here from CAM, the City of Detroit, and the VA, and I'm going to give them just a minute to say hi as well.
Good morning, I'm Alexis Alexander with the City of Detroit's Housing and Revitalization Department in the Homelessness Solutions Division.
Good morning, my name is Paige Beasley. I'm with CAM at Southwest Solutions.
Good morning, I'm Jennifer Tuzinski and I am with the Detroit VA.
Good morning, my name is Lauren Bianchi and I'm representing HAND.
Good morning, everybody. I'm Lauren Licata. I am with the City of Detroit's Housing and Revitalization Department with Homelessness Solutions.
Good morning, everybody. My name is Tawana Norwood, and I'm with Matrix Human Services.
Hi, Tawana. Welcome. We're happy to have you. All right. So just a little bit of logistics. We just ask folks to stay on mute if you're not presenting. I'm sure you guys are all used to Zoom by now. So we just want to try to minimize background noise as much as possible, but we do want you to feel free to ask questions and engage with the presenters as we're going through. So if you have any questions, please feel free to pop them into the chat. And then if there's opportunities, you may be able to unmute yourself throughout the presentation, but you can definitely unmute yourself at the end whenever we do the Q&A and engage with questions that way. We absolutely welcome that. But in the meantime, just we say try to use the chat, pop your questions into the chat. We've got a lot of folks here who may be able to answer your questions in the chat immediately as we go, or if we don't get to it in the chat, then we'll try to address it at the end. And then we just ask, if you're not presenting or actively asking a question, keep yourself on mute. All right, so with that, I'm going to dive into my section where we're going to talk about the continuum of care and what that is. So in essence, a continuum of care is a group of stakeholders. It's a local planning body that work together to try to coordinate their response to homelessness and deliver housing and services to persons experiencing homelessness that meet their individualized needs. and they try, a continuum of care it's a mandated entity. The Department of Housing and Urban Development, we call it HUD, they mandate that every local community develop a continuum of care that where it's that network of stakeholders who plan around homelessness, and they mandate that a continuum of care address 4 very specific pillars. So the first is that a continuum of care is able to identify persons who are experiencing homelessness, that they're able to link them to resources, that they're able to assess their needs, and then based upon that assessment, figure out what services are best for them and then connect them to those services. A continuum of care should have immediate and safe alternatives to sleeping on the streets. In Detroit, this is our emergency shelters and our warming centers that we have. Then they should also have a number of housing resources, some that are more temporary and some that are more permanent, that persons experiencing homelessness can be connected to. And then lastly, they should have like wraparound supports. So meet an array of needs that a person has, from mental health to physical health, to job care needs, whatever, to education. And if the agencies aren't providing those services themselves, then they should be linking persons to those services. So a continuum of care is meant to really kind of do what it sounds like. It should be a continuum of support, like an ongoing holistic level of supports. And so kind of touched on this briefly, but CoCs are designed to do a number of things. So first and foremost, to promote a community-wide commitment to the goal of ending homelessness. Everybody who's in a continuum should be actively working to make homelessness rare, brief, and non-recurring in the community. Then the continuum of care also is an entity which can apply to HUD for funding. And so we apply collectively, all the agencies in the continuum of care submit one application to HUD for funding. And then the money that is received from HUD is divided up among the various agencies based upon a local competitive process. Then we also, continuum of care works to promote access to effective use of mainstream programs. So really trying to link people to the supports and the services that they need, ultimately to achieve this bottom goal, which is to help folks achieve self-sufficiency, so that they are able to stay housed without needing additional supports. And so just to give a very brief history lesson, I don't want to spend too much time here. I know we can get in the weeds with this, but I just wanted to give a little information on the legislation that has led us to where we are today. So these major pieces of legislation really kind of help to shape the homeless response system as we know it now. And so the first important piece of legislation was in 1987, the McKinney-Vento Act. So this is a really important one because it's the first piece of federal legislation that was focused on homelessness specifically. This was the first explicit piece of legislation to address homelessness. Prior to that, most legislation was focused on lending programs designed to help individuals obtain housing, or subsidies and grants to generate the development of affordable housing in communities, but none of it was focused on addressing homelessness specifically, helping persons who are homeless get the supports they need to become housed again. And so, you know, we could also argue that some of the policies prior to this were the policies that unintentionally perhaps led to the entrenchment of community, unintentionally or perhaps intentionally, I think we could argue, led to the entrenchment of communities of color, and just like systemic poverty. And so this was a major breakthrough for us to have a legislation that really focused on helping folks who were homeless. And then in 1995, the next piece of legislation that's important was that HUD developed the continuum of care process. So that's when kind of this term continuum of care became a thing. And really the systems of care that we see now really first came into being. And so through this, HUD envisioned the local network of folks working together to try to address homelessness collectively as a community. And then in 2009, the Hearth Act was passed, which was really the first update to the McKinney-Vento Act and the only update that we've really seen. So it was another piece of legislation that really just affirmed the McKinney-Vento Act. And then it also added, it added in a couple of other elements, and it really just codified or solidified the role of a continuum of care in the communities, and kind of better help to define what HUD is expecting around that. Some important things about having legislation that address homelessness specifically. One that's important is that through this, there was a federal definition of homelessness that was adopted and recognized. And so why that's important is that allows for the government to then allocate resources to address homelessness because they've defined what it is, and then they can define what they want their resources to go to. So that was a win where then as a part of the McKinney-Vento Act and the Hearth Act, we're now able to receive federal resources to help address homelessness in the community, which is great. And then it also, in 1987, with the McKinney-Vento Act, established the USICH, which stands for the United States Interagency Council on Homelessness, which is a multi-agency, governmental agency body of folks who come together to plan and respond to homelessness on the federal level. And so through the McKinney-Vento Act, not only do we see collaboration at the community level to address homelessness, but now we see it at the federal level too, which we're really grateful to see. And then the last piece of legislation that I just wanted to point out to you was in 2012, HUD at the Department of Housing and Urban Development implemented the CoC program interim rule. And in that rule, they just really outlined their regulatory expectations for how local continuums of care should function. And then it also provided just some updates to previous legislation, which allowed for greater accessibility and less discrimination among services. So to give just a little more context, I like this image to show what it was like before continuums of care. So before continuums of care is a lot like this picture where things were just a little bit chaotic. Homeless services really weren't coordinating with each other. They weren't talking. So they were sometimes getting in each other's way. They were inefficient. You know, people weren't communicating with each other to say what they're doing. So a person who was experiencing homelessness was really just expected to figure out what services were available, figure out what was best for them, and then seek out those services on their own. There was no single point of entry for persons. It was also really focused on the individual project level. So each project was doing its own thing without consulting other agencies or other projects. And so sometimes what we would see is a lot of services addressing one specific need and then no services addressing other needs. And so you'd see gaps of services and resources available, or even like sometimes we would see programs competing with each other. And then ultimately, as this image I think shows really well, it was just difficult to navigate both for the providers as well as for the persons experiencing homelessness. So continuums of care were developed largely to streamline things, to create, this intricate highway system that we hear here. I think there's still a lot of room for growth, so I don't want to pretend like continuums of care are perfect, but I do think that we're heading in the right direction and we just need to continue to learn and adapt. And so ideally, a continuum of care model empowers a community to transition to, and I'm just going to read this quote directly because I think the National Alliance to End Homelessness put it really well. So it empowers a community to transition from a collection of individual programs that address homelessness separately to a crisis response system that makes strategic, data-driven decisions to achieve both program level and system-wide outcomes that help to make ending homelessness a reality. And then, as mentioned before, the federal legislation did allow for us to, or did create a definition for what an end to homelessness would be. And so, well, they defined homelessness, they also defined ending homelessness. And so I wanted to just make sure that you guys knew whenever we talk about ending homelessness, this is the definition that we are using in the continuum of care. So an end to homelessness means that every community will have a systematic response in place that ensures homelessness is prevented whenever possible or is otherwise a rare, brief, and one-time experience. So it recognizes that homelessness may not be avoidable at all costs in the current climate. And so if someone does experience homelessness, we really want to make sure that it only happens that one time and that we're able to get them housed and they're able to maintain that housing as quickly as possible. And so now I just want to zoom into the Detroit CoC so you can kind of get a sense of how we function in our structure. So HUD does mandate that every community have a continuum of care, but they do not necessarily mandate what that makeup should look like or how that should function. And so each continuum of care is able to kind of design how it functions based upon local needs. So here in Detroit, our continuum of care covers the cities of Detroit, Highland Park, and Hamtramck. We often will just say here in Detroit as shorthand, but it does cover Highland Park and Hamtramck. And so here in Detroit, our continuum of care kind of has a number of major players that work together. We've got the CoC general membership. Anyone is welcome to join that. We'll talk more about that at the end. And then we've got the CoC board, which is elected by the general membership as a kind of governance body of the CoC to kind of dive into the work, do some kind of strategic planning. And then we've got CoC committees that both general members or board members can join based upon membership requirements. Guests are welcome to attend any of these meeting formats. And then if you're interested in joining, we'll talk more about how you can do that as well. And then we've also got a number of designated entities that were appointed by the CoC to carry out specific pieces of the work. So we've got the CoC lead agency, which is kind of meant to be that strategic planning piece of the CoC, the collaborative applicant, which is responsible for applying for the funding from HUD every year, the HMIS lead agency, which stands for the Homeless Management Information System lead agency. They are the agency that collects, that really helps to manage our data tracking system, and we'll talk to you more about that later. And then the coordinated entry lead agency, which helps to design the system, the entry point for folks who are experiencing homelessness, and then to enact that entry point so that someone who's experiencing homelessness knows exactly where they need to go to get resources, and that they don't have to reach out to each individual resource, that they're able to access those resources from one common entry point. Everyone has the same point of entry to all the resources that we have available. And so with that, I did just want to give a little context of how the CoC, how the Detroit CoC fits in comparison to others. We are getting a little short on time, so I'm not going to spend too much time here, but I just wanted to help you see how the Detroit CoC stacks up against other CoCs. So across the nation, as of fiscal year 2019, which based upon HUD's timelines, that's October 1st, 2018 to September 30th, 2019. So based upon fiscal year 2019, there are 392 continuums of care across the nation. And then HUD breaks those up into a number of different categories. There's major cities. There are largely urban communities, which are also usually urban settings, but are not qualified as the top 48 major cities or the 48 largest cities in the US. Then there's largely suburban and then largely rural. So there are 21 continuums of care in Michigan, and Detroit, as you may be able to guess, it falls into the major city category. And so then for fiscal year 2019, HUD funded, so actually this one right here is fiscal year 2019, it will now cover 2020 because HUD just renewed it. But for fiscal year 2019, HUD funded $2.3 billion for homeless services across the nation. There were a few CoCs, 3 CoCs that didn't get any funding, so they got 0 funding. But the smallest CoC, beyond taking out this 0 funding, got $2,962. The largest CoC got $133 million, or the largest funding amount. That wasn't based upon size. So the largest funding amount awarded was $133 million. And then Detroit received $27.3 million. So you can kind of see where we fall in that. I also put the median and the mean here if you're interested in that. And then lastly, annual count. This is based upon the system performance measure annual count, which is a data piece that HUD requires communities have. One thing to note is this count only captures persons experiencing sheltered homelessness. It doesn't capture those experiencing unsheltered homelessness. So the smallest CoC had only 10 persons experiencing homelessness. There were 3 CoCs that reported 0 persons experiencing homelessness that year. The largest number of persons experiencing homelessness in a community was 138,000. For Detroit, we reported 7,099 persons experiencing homelessness. So you can see kind of where we fall. And then to show some trends of numbers experiencing homelessness, this graphic shows persons experiencing homelessness, both sheltered and unsheltered. So that's why you see this number a little bit differently. And so this just shows the trends. And so you can see that thankfully over the years, we've been slowly helping to lessen the number of persons experiencing homelessness in our community. And we hope to continue to go in this direction. And then just briefly, if you're interested, we'll make these slides available to everybody. So I don't want to spend too much time here, but this is some information from our annual report, which just shows some demographics of people experiencing homelessness. This is from our 2019 annual report. And just a little blurb here that we're working on developing the annual report for 2020. And when that's created, it will be published on HAND's website, which there's a link here in the slide and then a link later in the slides as well. And so from here, I'm going to turn it over to folks at the City of Detroit to talk to you about the definition of homelessness.
Good morning, and thanks again, Katie. So in the prior section, you got the chance to hear about many of the laws and regulations that resulted in formalizing our homeless service system into a continuum of care. And to take a closer look at the people that our CoC serves, I'm going to share with you how the Department of Housing and Urban Development, or HUD, and the state of Michigan define different categories of homelessness. Later on this morning, as my colleagues go into more detail about the different services that the people at your agencies are able to serve and get connected to, these definitions will help you in understanding who is eligible. And just a reminder, as Katie shared, these slides are going to be emailed out following our presentation, so you can reference them as needed. No need to worry about trying to jot down every word. So the first definition we have is the literal homelessness. These are individuals who lack a fixed, regular, adequate nighttime residence. They may be sleeping on the streets, in an abandoned building, places not meant for habitation, or within an emergency shelter, transitional housing, safe haven program, or hotel or motel paid for by a charitable organization. For individuals who are exiting an institution where they stayed for up to 90 days, if they entered that institution from a shelter, the streets, transitional housing, or safe haven, they are still considered to be literally homeless. Next slide. You're going to also hear us refer to the chronically homeless. So this is a subset within the literal homeless. These are persons who have, number one, a disabling condition. You'll need to remember this. The person must have a disabling condition, and they are living in a place that's not meant for habitation, again, the streets, abandoned building, etc., a safe haven, or an emergency shelter. And again, if that person is currently in an institution, but they've been there for up to 90 days, but came from one of those situations, they still maintain their literal homelessness. And they have been literally homeless for 12 months straight, so at least a year altogether, or across 4 separate occasions in the last 3 years. The length of those total combined occasions totals at least 12 months. So when you hear us referring to programs that serve the chronically homeless, please remember that the person is literally homeless, they have a disabling condition, and they have at least a year's worth of being in a shelter, on the streets, or in a safe haven that can be verified. Next slide. For some of our programs, you will hear that they can serve persons who are at imminent risk of homelessness. This means that a person or a family stands to immediately lose their primary nighttime residence. Within the next 14 days, the individual is unable to find any assistance to resolve their situation, and they lack the resources and supports to obtain other permanent housing. This comes into play when you hear us talk about some of our prevention programs. Next slide. There are also individuals who may be qualified as homeless under other federal statutes. These include unaccompanied youth under 25 years of age, as well as families of children and youth who do not otherwise qualify as homeless by the definitions you've heard. But they may not have had a lease for at least 60 days prior to asking for help. They've experienced persistent housing instability, so that's qualified as 2 or more moves within the last 2 months, and they're expected to continue in this status for an extended period of time. Next slide. Individuals who are attempting to flee domestic violence include any person, could be a family, single, who is attempting to flee domestic violence. They have no other residence, and they lack the resources or support networks to obtain other permanent housing. Next slide. Additionally, you'll also hear us refer to individuals who are at risk of homelessness. This includes individuals or families who have an annual income below 30% of our area median income. Some of our prevention programs that are coming on board may have slightly different timelines here. And they do not have sufficient resources or support to prevent entering literal homelessness. And, next slide. Due to economic reasons, that household has had 2 or more moves in the last 60 days, or they're living in the home of another, you may hear us refer to that as being doubled up. That household has been notified that their right to occupy their current housing will be terminated within 3 weeks by the time they come to you seeking help. They live in a hotel or motel paid for by a charitable organization or government program, or they live in a situation where the number of bedrooms is not sufficient for the number of people in the household. So if it's an efficiency apartment, having more than 2 people counts, or if it is housing with multiple bedrooms, greater than 1.5 persons per room. The person could be exiting a publicly funded institution or system of care, or otherwise is living in housing that is unstable and at increased risk of homelessness. So again, when you hear us referring to who our prevention programs can serve, these individuals have these situations going on. Next slide. Additionally, HUD defines unaccompanied children and youth. They may not qualify under some of the homeless definitions that you've heard earlier, but there could be other federal statutes, especially with regard to schools, as well as with our runaway and homeless youth, that they are counted as homeless. And then we have families with children and youth. This includes unaccompanied youth who, underneath the McKinney-Vento Homelessness Assistance Act, as well as their parents and guardians, they are qualified as homeless. And I did see a question about what a safe haven is. We will be getting to that in just a moment. We'll be sure to get that question answered for you. Next slide. All right, so answering that right along, what are some of the services and programs within our CoC? So the different funding that you're going to hear about in a minute and that make up the programs that Katie shared earlier roughly break down into a couple of categories. We have emergency shelters. These offer temporary short-term overnight accommodations. In the past, they were previously limited to 90-day total stays. That is not the case currently. And any person who's experiencing homelessness is eligible to be served by emergency shelters. We also have safe havens. These offer temporary overnight accommodations. And locally here in Detroit, veterans who are being served by our low demand grant and per diem programs are counted as being within a safe haven. They do not require any type of sobriety or treatment participation to be served there. Transitional housing, this is another sort of temporary overnight accommodation. The stays can last up to 2 years. They are able to serve persons experiencing homelessness that meet special criteria here in our CoC. So oftentimes you'll hear about our grant and per diem programs, which serve vets, as well as pregnant and parenting youth, and persons seeking asylum here in the United States. Those are the main categories that transitional housing serves here in Detroit. Rapid rehousing provides rental and utility assistance, as well as housing relocation and stabilization services that can last up to 2 years. Because we have many different funding sources for our rapid rehousing programs, you may see that they have a cap on the length of time they can be served. So this is just to let you know, has to be under 24 months. And then persons who are experiencing literal homelessness that score for rapid rehousing on our vulnerability index and meet additional local prioritization criteria can be made eligible for rapid rehousing. You'll also hear about PSH or permanent supportive housing. This is long-term housing that is paired with supportive services. So in this situation, households must have at least one person who has experienced homelessness and has a documented disabling condition. They must score for PSH on the VI-SPDAT, our vulnerability index. And we have some additional criteria that our CoC uses to prioritize this resource, especially for individuals who are experiencing chronic homelessness. Next slide. Prevention programming. So these programs offer rental and utility assistance, as well as housing relocation and stabilization services. They're able to serve individuals who are at imminent risk of homelessness, as well as homelessness under other federal statutes, persons fleeing or attempting to flee domestic violence, and they have an annual area median income below 30%. Some of our programs may have a slightly higher cap. Again, more detail is available program by program. Street outreach. This offers one-on-one engagement with unsheltered persons to get them connected with emergency shelter, help them meet basic needs, and hopefully link them to street navigation. Any person who's sleeping on the streets, in a car, an abandoned structure, or another place not meant or fit for habitation can be served by a street outreach program. We also have street navigation. So this is a special category of outreach teams that do one-on-one engagement with unsheltered individuals with an emphasis on persons who are chronically homeless. Again, they have that disabling condition and they've been experiencing homelessness for at least 1 year straight or across 4 instances over the last 3 years. And the focus is on following them and making sure they get connected to a permanent housing. We also have supportive services only. So here locally, that is coordinated entry or the CAM. They assess each individual who is in need of housing as well as their related needs and figure out how to connect them with diversion, emergency shelter, or other permanent housing supports as appropriate and available. Any person experiencing homelessness or at risk of homelessness can seek services through CAM. And then finally, we have infrastructure and oversight. This is the group that's responsible for planning, collecting data, analyzing, and applying for funding to support the various programs in our system. And ultimately, it impacts and serves all persons and all programs in our CoC. And I did see another question about the local prioritization for rapid rehousing. I believe we may go into that a little bit later on this morning. If we don't, we'll make sure to follow up and share with you where that information is, Alyssa. All right, I'm going to turn it over to Lauren.
Good morning, everybody. I'm going to be talking to you guys about funding as well as the grievance process. So this is a chart. I won't go through everything here, but this is a chart of all the funding sources supporting Detroit CoC programs. So on the left here, you can see a column that shows all of the different types of programs that we have here in our CoC. And on the top row, you can see all the different funding sources. And it will show what is funded. So if you're looking to potentially open up an emergency shelter, you can use this chart to see who can I apply for funding with, and if I want to open up an emergency shelter. And you can see from this chart, emergency shelter, you would apply through ESG, ESGCB, CDBG, and as well as ESP. So this is a great reference chart for using that. Next slide. CoC grants. Each year, the CoC lead agency, which is HAND, calls for new applications to fund projects identified as priorities in the annual HUD NOFA. You can subscribe to the HAND newsletter or check out HAND Detroit/Continuum of Care funding to receive updates of when funding is available. In 2019, 2 new projects were awarded funding from HUD to offer permanent supportive housing within the Detroit CoC. In 2020, HUD renewed 2019 allocations. Nationally, new project funding was not made available, and that really had to do with the coronavirus. So CoC funding, as you can see here, a majority, 19.5 million, goes to permanent supportive housing, and then, and the next big chunk goes to rapid rehousing for $3.4 million. CoC funding is really focused on those permanent support or those permanent housing solutions to end homelessness for folks, as you can see here, as well as CoC planning, HMIS, coordinated entry supportive services only, and then transitional housing and transitional to rapid rehousing programs. The Emergency Solutions and Community Development Block Grants. So this is through the City of Detroit. In 2020, a little over $14 million was allocated. A majority of that did go to emergency shelters, and then the next biggest chunk was rapid rehousing. Each year, the City of Detroit's Housing and Revitalization Department requests for proposals for emergency shelters, foreclosure and homelessness prevention, rapid rehousing, and street outreach programs. The link for the application is there. We will be releasing, Alexis, correct me if I'm wrong, but an RFP for the 2022 year, probably sometime in May. She did not correct me, so I'm going to say that's correct. So be on the lookout. Yep. Yeah, so be on the lookout for that if you're interested in applying for any of the programs. Emergency shelter, coordinated entry, which is done through the lead agency. Street outreach and navigation, rapid rehousing, homelessness prevention. Oh, thank you, Katie. RFP is request for proposals. The VA permanent supportive housing funding. HUD BASH is similar to what the CoC calls PSH. It is a voucher along with supportive services. They have 912 vouchers, 897 through MSHDA for the 4 counties. 35 are project-based. Project-based just means that they are attached to an apartment building, that they can't be moved from site to site. 15 for St. Clair County, specifically through the Flint Housing Commission. And then there's SSVF. All providers received 103% increase in the fiscal year 2021 budgets. Southwest Solutions received a little bit over 2 million. Blue Water received between $40,000 and $500,000 for Detroit temporary financial assistance cases, and the Volunteers of America received about a little over 1.5 million. 40% of this budget is slated for TF8 cases in Detroit. Grants are available through the Federal Register and are updated daily. Information can be found at www.federalregister.gov. So now I'm going to talk a little bit about the COVID-19 response that we've had here in Detroit. It really is a 5-part process that we've had. So this first step here that we've taken is response implementation. So created responses for sheltered and unsheltered populations, coordinated with other funders to relax rules. One of the big things with this was the ESP funding for emergency shelters. It used to be a 90-day rule that you could only stay in shelter for 90 days, and then you either had to find somewhere else to go or go to a different shelter. That rule got eliminated, which is great, and then created key collaborations, including health partners. So we have a really good connection with the Detroit Health Department, as well as Henry Ford Health Systems, and some of the other hospitals that are downtown. The second process here is communication and collaboration. Regular interagency calls. We are calling all the time to our other agency partners, to HAND, to CAM, to the VA, and then also to each of the agencies to go over any issues or problems and try to solve them. We have bi-weekly Friday webinars that are sponsored by HAND, the city, CAM, which is wonderful. It's a way that you guys can get information. I think we'll have a slide maybe with how you can connect to that at the end. If not, we can plug that into the chat box. But yeah, we have updates about COVID-19. We have updates about the CoC, any funding that can be available. We have success stories and then problems that have been solved. And then we also send out a monthly situation report. The third step is isolation and overflow shelters. So because of COVID-19, a lot of shelters had to decrease the capacity. A lot of shelters were really crammed together in congregate settings, so they had to decrease their capacity. So we opened overflow shelters to increase that capacity. And the overflow shelter, I'm sorry, that we opened was DRMM Oasis. And then we also opened up shelter type 1 and type 2. This is a shelter that will house people that are symptomatic and awaiting test results. And then type 2 is those who are COVID-19 positive, so they don't have to remain in shelter. The next is the testing and vaccine strategy. So we use public health nurses. There are 3 rounds of vaccines at congregate and unsheltered programs, NOAA and the Pope Francis Center. We're on our 3rd round right now, and we are heavily advocating for the vaccines to continue. But that's really up to the Detroit Health Department. So we will continue to update everybody about that at our Friday webinars. And then we have regular testing scheduled for congregate and unsheltered programs. During the heat of COVID-19, primarily we had a huge increase from November to about January in the emergency shelters. So we were doing testing bi-weekly. Now things have kind of settled down, knock on wood. And so we're going to be moving next month to just once a month. And lastly, centralized supplies and funding. PPE distribution for agencies, addressing resource gaps system-wide, additional funding and donations. Oh, and then vaccine distribution should have been up there. I apologize. Addressing concerns within homelessness service providers. So individuals who feel they have been wrong can file a grievance directly with the agency. If they are unsatisfied with the result of this or fear retaliation, they can complete a consumer grievance form available at handdetroit.org/documents or at any CAM access point location. And I should have updated this. CAM can still help folks file a grievance. It will just be over the phone and not at a location. And then HAND or other City of Detroit staff They will review the grievances, investigate them, reaching out to the person that filed the grievance and the agency with the grievance is filed against. So really, we take concerns very seriously. We want the concerns to be filed with the agency directly, but understand fear of retaliation and folks not feeling comfortable or not getting the answer that they want from that complaint. So we ask them to file a grievance with the CoC. And then next slide. I see Katie's plugging in the chat box a way that the CoC grievance procedure. Depending on the outcome of the investigation, the CoC Grievance Committee is asked to review the details collected and make a decision about the next steps to rectify the matter. And then, I don't know if this goes to Jennifer or is staying with me.
I can go over it, Lauren.
Okay, thanks.
It's fine. Yeah. So with any veterans who are in either our homeless programs or receiving homeless services, if they have a grievance and they're in one of our agencies, so that could be GPD, Contract Residential, or SSVF, and we'll talk a little bit more about what all of those mean. They would first file a grievance with the agency. And if they are not satisfied with the outcome of that, they would then file a grievance with their assigned liaison. So there's a staff person at the VA who acts as a liaison between the agency and the VA, or the chief of the HCHV program. So that's the supervisor who oversees the liaison and the programs within the community. They can also file a complaint with the patient advocate at the Detroit VA Medical Center. And then because we are federal, any veteran at any time can file a complaint directly to a Congress member. So there are multiple ways for veterans to file grievances and ensure that they're followed up on.
Lovely, thank you guys. So now I'm going to turn it over to Paige Beasley with Cam, and she's going to talk to us about how folks can access services in Detroit.
Awesome. Thanks, Katie. Thank you everyone else who presented. So we got a lot of great content about the CoC oversight and just how the system kind of comes together. And I get the honor of talking about the coordinated entry and how people are actually connected to the services. So if we can go to the next screen. So what is CAM? A lot of you may have heard a lot about CAM. CAM is the Coordinated Assessment Model. That's the acronym for Coordinated Assessment Model. We are Detroit's local coordinated entry system. As Katie alluded to earlier, we do service Detroit, Hamtramck, and Highland Park. Detroit is the major city. So we do, we coin ourselves on Detroit, CAM Detroit. We connect people who are experiencing homelessness or at risk of homelessness to shelter and housing resources. We are not a program, but or organization. We are the process to get people connected from one point to the next. Next slide, please. Okay, so why does CAM exist? So Katie talked a lot about this earlier in her presentation, but HUD does require each continuum of care, the CoC, to operate a coordinated entry system and require the CoC and ESG funded programs to use the coordinated entry system. So the purpose of CAM or the coordinated entry is to, just gonna move this right here, is to create a consistent and streamlined process for assessing the resources that are available to the homelessness response system. We are responsible for prioritizing the resources for the highest need in the most vulnerable households, especially when it comes to a restricted amount, not a restricted amount, but a limited amount of resources. We are also responsible for ensuring that housing and supportive services are used as efficiently and effectively as possible, and to transform a network of independently operated projects to a fully integrated crisis response system. Next slide, please. So what's new with CAM? This is a newer slide. We've done this presentation a couple of times, and so we have recently underwent a couple of changes that have definitely, I think, bettered the system in general, our CoC in general. So we have recently underwent a veteran integration. Jennifer is going to talk more about the veteran system in her presentation. But what we did do was we created, we became the access point for veterans who are experiencing housing crisis as well. We also underwent a homeless prevention integration, and I can speak to that a little bit later. But pretty much we are the access point as well for households who are experiencing housing insecurity and is at risk of homelessness. And so we kind of in our community we talk a lot about prevention, and we kind of decipher the two between homeless and eviction prevention. And so there are still opportunities for individuals who are experiencing homelessness to still gain access for eviction prevention through the specific providers. And but the homeless prevention does come through the CAM access point at this time. All right, so let's walk through the CAM process. We tried to do a little pretty grid to kind of help kind of walk through. So we're going to take a journey through this process really quickly. So first off, who we serve. So at this time, CAM serves individuals and families and youth who are experiencing homelessness or who are at risk of homelessness. Next slide, please. So what that kind of goes into is based off of HUD definitions. We address the needs for the individuals who are considered literally homeless, fleeing or attempting to flee domestic violence, or who are at imminent risk of homelessness. And so Alexis gave us a very detailed presentation on those homeless definitions. And so CAM team, we solely assist these individuals with connecting to resources to get them back to the housing component. And so again, this includes the individuals and families and youth who are experiencing homelessness or at risk of homelessness. So we operate at CAM, the CAM phone line right now. That was an immediate response to COVID. So prior to March 2020, CAM were operating 5 access points, and these were walk-in centers with anyone who were experiencing housing crisis were able to come in, get assisted, and be able to get connected to resources. And so we have ramped up a phone system again, as a result of COVID. And so during this CAM process, individuals will be able to come in and get access to the services. And so it looks a little different depending on what the specific need is, but they can actually get an assessment for diversion. If it determined the shelter is needed, then there is the VI SPDAT tool that we'll be using. If prevention is the need, then we'll be looking at a prevention assessment tool, referral to shelter, and confirmation and navigation appointment as well. And I did not speak specifically to street outreach during this presentation, but street outreach for individual are providers who assist individuals who are unsheltered, and they provide the same services that we do at the access point. We do it for individuals who are going into shelter, or going into shelter. Industry outreach are doing this on the back end for our unsheltered clients. Next slide, please. So CAM access. So how do people get connected to CAM access, right? Again, right now we're doing the phone line. So this is the phone line, 313-305-0311. Monday through Friday, 9 a.m. to 6 p.m. And then Saturdays, 10 a.m. to 3 p.m. We are closed on Sundays. Unofficially, we have not made extreme announcements about it, but we are also at the NOAA project Monday through Thursday as well. 8 a.m. to 3 p.m. To make sure we can kind of connect with individuals who are unsheltered as well. And CAM is continuing to look at our ramp up plan to go back in person as well. So more information will be coming about more access opportunities for CAM. Next slide, thank you. Okay, so we're going to talk about the process of diversion. So a household contacts the CAM access point and they are seeking shelter. Our CAM team is tasked with trying to figure out if there are any alternative solutions other than shelter that we can connect them to. And so it's a number of reasons why we try to explore the diversion route. We know that limited resources come into place. And so if someone has a safe space for the night and someone else doesn't, then we definitely want to make sure that we can get that individual who would be unsheltered into into a safe bed for the night. So we are going to look into diversion opportunities. CAM is also funded by the city of Detroit with a small pot of money to be able to assist with some diversion resources. So in the event we have any options where we can connect people with other family or friends, and be able to provide a small financial contribution to get them there to avoid homelessness, and we'll be able to explore those opportunities. And so as you see, if the household is diverted, if the diversion was successful, then that household is connected to a safe place for the night by the visual. Next slide, please. All right, so diversion, I kind of just talked about it, but it is the problem-solving approach to help people seeking shelter identify safe, immediate alternative housing arrangements. In 2020, CAM diverted about 2,287 households. That's about 29% of the engagements that we had at the access point. Sorry, my children coming in. So I'm so sorry. This is working from home at its best. Okay, so the next piece. um, excuse me. Apologies. Okay, so the next piece is talking about prevention. So at the access point, this is something recent. We are currently assessing individuals who are experiencing at risk of homelessness, right? And so at the access point, we are able to complete an assessment tool, and then we are able to, based off that assessment tool, connect them to the prevention resources at the access point. Those households would receive a prevention referral and then be connected to further determine eligibility and equal, and then I'm sorry, and then end up with housing at that point. We can go to the next slide. So, prevention, it is a service intervention that is designed to assist those who will imminently lose their primary residence, and it prevents them from actually entering into the homelessness system. So, the assessment tool, which is different from our VI SPDAT, is administered to determine what the eligibility, if they are eligible for that resource. So, this is new. CAM recently started working with the city of Detroit and the providers as of February 2021, to start making referrals to the homeless prevention providers. And so we don't have a lot of data as of yet of what this is looking like, but I'm hoping during our next presentation for the CLC, we'll be able to pull in some prevention information to kind of figure out how many people were prevented from entering into the homeless system as well. I did see a question about prevention and diversion. Very great question. I think a lot of people are. So I'm going to go ahead and continue with the presentation, and I can kind of speak to more about the diversion versus prevention. So CAM process for shelter. So in the event CAM staff were unable to divert a household, or prevention was not a realistic option for this household, they were going to be homeless tonight, right? So we needed to explore what other options we could do. And so shelter is going to be that option to making sure they have somewhere safe to stay. So if the household does enter into shelter, our team is going to complete an assessment tool with them. So that way we can determine what type of housing services they could be eligible for, if any. And so we'll go to the next slide so we can take a look at what the shelter programs look like in Detroit. So in Detroit, these are the facilities that we currently make referrals to for, well, some in terms of from the access point. The YWCA interim house is not a referral that CAM makes at the access point, but we are able to connect people if they happen to be fleeing domestic violence. So there are an array of different facilities. We work with all of these partners to make sure that we can have somewhere safe to stay for everyone. Okay, so the household is in shelter. They are eligible based off of the VIs for that. And then we can go ahead and connect them with our navigation team. So our navigation team is going to complete further documentation and further assessment to be able to see if they're eligible for any resources at this time. You can go to the next slide, please. So based off of the consumer's vulnerability assessment, which we talked about, a recommendation is going to be made for the housing intervention. So housing interventions can range from transitional housing, rapid rehousing, the housing choice voucher application through MISHDA, or permanent supportive housing. So our navigators meet with the consumers. They were doing face-to-face in shelter. And so now we're on the phones, and then now we're actually bringing in a telecommunication process as well. So that way people can still meet within a virtual sense while in shelter. So they meet with the clients and gathering the necessary documentation. If it is warranted, additional assessment is completed to further determine any housing needs as well. And then the street outreach, as I had stated earlier, they do provide the navigation and the access for the unsheltered consumers. And so based off of that, what happens with navigation, there is a prioritization that we use that kind of takes into account individuals' current status. Are they in shelter or not in shelter, or pretty much are they are they sheltered or unsheltered? Is this a family? How long have they been homeless? Considering any domestic violence. So all of these factors are taken into consideration, and basically when when a opening becomes available, then that household would be referred over to the next resource. And so we can talk about referrals and our referral partners. So it is a little small. I apologize in advance. However, our referral partners, the list has expanded. So we have so many more partners on board that CAM are able to refer to. In the integration of the veteran system, we are currently referring to our veteran SSVF partners and HUD-VASH. We are also referring to new projects that came on board as well. So there are a number of prevention, TH, rapid housing, and PSH providers that CAM are able to refer over to for housing placement. And the next slide. So special populations. So within the homeless population, of course, we know there are going to be special populations that we need to address specific needs for. And so those include survivors of domestic violence, the veteran population, and also youth and LGBTQ. So for these specific populations, there are specific resources that are available for this population. So we have specific shelters, TH program, rapid rehousing programs for survivors of domestic violence. We have shelters and specific housing programs for veterans. And most recently, well, not most recently, for youth, we have youth specific housing programs and shelters as well. I would say the most recent thing is for the LGBTQ community. We have recently brought on board a housing project specifically to service that particular community. And so we are working to kind of just make sure that we are providing the wraparound services as a community to these groups. Next slide. All right, so this is not my piece, but there was a question about diversion versus prevention, and which was a really great question. So I think a lot of communities are still struggling with how to identify that. And so for CAM and for Detroit, I think we agreed to look at it as we would utilize diversion resources in the event the household was going to be homeless at that particular night. So there were no other options available. And then prevention, where the imminent risk is meaning that they're not quite there at homelessness yet. And so there's still some time and there's some work that needs to be done to prevent them from entering to the homeless system. But diversion is they're right there at the door of homelessness. And so our efforts have diverted them from actually entering into the homelessness system. I hope that was helpful in answering. You can chat in the box if not.
Paige, we have another just quick question too, where someone was talking about access to services. So the question was, if someone has to be in a specific shelter in order to access navigation services through CAM. So they said, what if someone does not need to be in an emergency shelter, but needs assistance with transitional or permanent housing?
Okay, so, and I would answer that question with potentially asking another question, or kind of giving a caveat that it's really going to be dependent on what that client's housing status is for us to be able to determine what type of resources we could potentially connect them to. So if they are in a situation where they're going to be at imminent risk of losing their housing, we could technically assist them through the new intervention that has started through homeless prevention that would not necessarily have them enter into shelter, but maybe that would be a resource. So it's really going to be dependent, because a lot of the resources through the CoC that are referee housing, transitional housing, and the permanent supportive housing, they do have a caveat by the funder, by HUD, that it does have to equal a category 1 homelessness, meaning literally homeless, or fleeing domestic violence homeless.
Yeah, and that's as Paige said, that's a limitation that's put federally. So that's where sometimes we run into hurdles with implementing resources that are federally funded, is HUD has very narrowly limited who qualifies for those supports. And then someone just wanted to ask too about mental health, like how we screen for mental health and how that impacts the vulnerability assessment.
Good question. So mental health is something that we do ask about disabilities in an effort to better assist with identifying needs. It is not a caveat to shelter or housing. It's not a caveat, meaning like it's not contingent on housing or on your housing or shelter, but it is as to better understand what the needs are. And so we do ask about self-report, and then our navigators work really hard to gather documentation to support that, to be able to qualify for certain housing projects. Hence, Alexis talked about the chronic definition. And so those clients, those individuals would have to meet um, a level of disability in length of homelessness. And so we would need that documentation. We would need that to be understood in terms of how we can move forward with housing.
Well, thank you so much, Paige.
No problem. You guys will hear from me again.
All right, I'll turn it over to Jennifer now to talk to us specifically about some veteran-specific resources.
So this is a little bit difficult to read, I realize, but this is our the coordinated entry process for veterans. So as Paige mentioned, we have now merged our systems, and she talked a lot about the CAM process. So I'm just going to touch on where the VA comes into this. So once CAM has completed the assessment, the veteran is referred to shelter, and the first shelter option is MBF because they serve veterans only. But it's ultimately the veteran's choice. So if they wanted to be placed in a different shelter, they can do that. That's completely fine. At that point, then CAM notifies VA staff that a veteran has been assessed, and VA staff reaches out to that veteran and schedules an appointment to complete a more in-depth clinical assessment on each veteran. And so they go ahead and do that. It's about an hour long. We really dive into like mental health, substance abuse, if they are combat vet, anything that might be related to PTSD, those types of things, making sure that they are connected to services that are available at the VA. Because sometimes we see veterans that come through that don't even know that they're qualified for VA services. And that's one of the things that merging the systems has filled as far as a gap. So we're now able to make sure that all veterans are connected with the services that they're eligible for, which has been a wonderful thing. And so then once they are assessed, we determine whether or not they're going to transition over to our transitional housing programs, or if they're going to stay in shelter. And that's really based on the clinical need of that veteran. So it's done on a case-by-case basis. Next slide. So one of the things that you will notice that's a bit different from the civilian side of things is that there is an abundance of housing resources for veterans. And this is just a whole list of the different resources that are available. So one of the areas is the VA is full of acronyms. So we have the Healthcare for Homeless Veterans, that's HCHV. That is our homeless services that are available at the Detroit VA Medical Center in Midtown. So there are staffed licensed social workers there that help connect veterans to whatever medical services they may need, mental health services. They do provide case management as well for those veterans. And so that is oftentimes we have veterans that actually walk in, or they might be seeing a doctor and they can actually just walk into that department and get the care and the services that they need. We also have a Veteran Community Resource and Referral Center, or VCRC, and that is located offsite in the Paquette building downtown. And that is a center that is specific to homeless veterans. They also will be referred to medical care if they need it, or mental health services. And there is actually a medical center on site there, because what we found is that sometimes homeless veterans did not feel comfortable going to the large hospital. It was just a bit overwhelming. And so VCRC centers were created for those veterans who wanted a more a smaller type setting where they felt more comfortable, so they can get their medical care there. There's also some ancillary services, so they can take showers, they can wash their clothes. There's often meals available, and clothing, and various other resources that are available for them. And we do have our licensed social workers on staff there too, to help connect them with services. Our grant per diem program. So that is our transitional housing program within the veteran system. And there's another slide where I'll break it down as far as who all those providers are. The grant per diem program is a, like I said, a transitional housing program that based on clinical assessment, the veterans could be referred to those programs. And in order to qualify, really the basic criteria is that they have to have served at least 1 day active duty in the services. Contract residential is also another type of transitional housing. We have one here in Detroit and two in Wayne County. And that is just a little bit different. In order to qualify for that program, they actually have to be eligible for VA medical care in order to be referred to that facility. And again, it's also based on clinical need as well. We also have a domiciliary, and that provides inpatient mental health or substance abuse treatment. It's usually up to 90 days, but they can be extended. So that is another resource that we do a lot of referrals to for our veterans. One of the newest things that we have that came on board last year was a case management grant specific for veterans that's came out of DRMM. And that is for veterans who need that additional case management support. So they may have been housed in a, say, our rapid rehousing program, or just on their own. They sometimes we have veterans who have a significant high income just because they're connected to services at the VA. Maybe they were injured in combat, and so they have a larger income, but they still need case management support when they get housed. And so that's where this grant comes in. They are able to provide additional supports to that veteran to help stabilize their housing for up to 6 months. We also partnered, we have an agency, Community Solutions, that is partnering with our community, and they have also made connections with Quicken Loans. And so we have a veteran housing fund, and that is available to any veterans who are on our by name list. And I don't know, I think it's been mentioned, but just so the by name list is actually a list of all the homeless veterans that are in Detroit. So we maintain that list, and we track where our veterans are going and what resources they're connected with. And so for this fund, any veteran that is in one of our grant per diem programs or contract residential programs, if they exit to permanent housing, they can actually be given up to $1,000 directly to them to help support them in transitioning to permanent housing. So some of the things they've helped them with is, like moving costs if they weren't able to get that help someplace else, or storage fees, just things like that that are a little bit of a barrier that some of the federal funding doesn't allow us to do. This gives us that flexibility to support those veterans to permanent housing. Also, our supportive services for veterans family is our SSVF program. We have 3 agencies in Detroit that have those grants, and those are our rapid rehousing programs for veterans. So those are veterans who score along the middle area of the VI SPDAT that might not need super intensive case management on a long-term basis, but just need that support to help stabilize them, get them into permanent housing, and then they can be case managed up to 9 months, though there's some flexibility right now with COVID. But they, really help to get them stabilized, connect them with maybe employment services or applying for disability benefits and things like that. And then finally, our HUD-VASH program, which is what a lot of people talk about, want to know a lot about. So this program is a voucher and intensive case management program. And so in order for a veteran to qualify, they have to need long-term intensive case management services. So when I mentioned that the VA staff do a more in-depth clinical assessment, that is what they're looking at. Is there long-term mental health conditions that needs that ongoing case management support? It does provide a subsidy, so they pay 30% of their adjusted gross income towards the rent. But the key here is that they also have to qualify for intensive case management supports. And so, as mentioned before, we have a lot of vouchers in the city of Detroit. We have about 112 that are still open. And so that is not, a resource issue that we have right now, which is a great thing. So any veteran that comes through our system, we're able to identify them, do the referral over, and we can automatically, connect them with the voucher as long as they qualify. Next slide, please. So as I mentioned, we do have the GPD and contract residential beds. So I just wanted to give this because I get tons of questions all the time about who are the providers, how many beds do you have? And so this is what that shows. So we have 3 GPD agencies. Our newest one is Operation Welcome Home, and they have a total of 30 beds. They predominantly serve female veterans, though they do have 5 male beds. And you'll see the bed types on the top. I did provide a slide, the next slide, which we'll go to in a minute, which will explain what each bed type means. And then we have Michigan Veterans Foundation, so we have 104 total beds there, and Volunteers of America has 60 total beds. And then, like I mentioned, we have our contract residential agency. So in Detroit is Faith, Love, and Kindness, and they have 14, and they are all male beds. And then we do have the 2 outlying counties that we can refer veterans to. They do remain on the Detroit by name list, so we can track them and make sure they get to permanent housing. But because Safe Step does take females, sometimes we do have a female veteran that might be a better fit for Safe Step than, say, Operation Welcome Home. And so we are able to do those referrals to those different agencies in the out counties. And sometimes we have veterans in the out counties. And by out county, I mean Out Wayne, Oakland, Macomb, and St. Clair County, where sometimes they do need to be placed in a grant per diem bed in Detroit, and that's completely fine. We have worked out a way to coordinate that and make sure that those veterans are tracked throughout the system. Next slide. And as mentioned, so this is, I won't go through super detail because I know we're getting close to time, but in case you wanted to know what those bed types mean, this is a definition of all of those different bed types that are in our grant per diem programs. And you can always reach out if you have questions about that. Right now, we are, and have been for a few years, have an abundance of transitional housing beds in Detroit. So that is not an area that we need like additional beds within the community, which is, it's nice that we have that option. So we're looking at, some different things that we could do to try to make some changes within our programs, but that'll be forthcoming in the future. Next slide, please. And I just wanted to give this information. So this is our data for 2020, and this is our inflow and outflow success that we had. So we had 308 beds come into our homeless system in 2020. We had 339 moved to inactive, and 216 were placed into permanent housing. The inactive means that these were veterans who came into the system And maybe after 90 days, we weren't able to get in touch with them. We lost track. Sometimes we have a lot of veterans that move out of state. So sometimes they leave, they don't let us know where they're going, they move out of state, and then after 90 days, they're made inactive. We also did a huge data cleanup in 2020 of our by name list. So we were able to go through different databases and really like clean that list up. So we have a very clear understanding of who our veterans are in our community and who are still homeless. So the great thing is that we did reduce our veteran homelessness by 33%. And our goal for this year is to reduce an additional 40% with all the different resources that we have available. And now that we are connected with CAM, we're really excited and we are very hopeful that we can do that. So as of December 2020, we have 170 homeless veterans in the city of Detroit. Next slide. And that was my piece. So thank you very much.
All right, so I'm about to turn it over to folks with our HMIS team. I just wanted to do a quick time check. I recognize that it is 10:24, so we have about 6 minutes left, and I know the CAM team had said that they would need the full 15 minutes, and then we had some ways to get involved for folks. So I just wanted to do a temperature check. Are our presenters able to stay a little bit late? And then would folks mind staying a little bit late for us to go through this? I think we've unintentionally just been a little bit verbose today. All of us have been. So are folks able to stay a little longer so we can get through everything?
Katie, I have a meeting I have to jump off on, but I don't know if there's much else.
Okay, if we get any veteran specific questions, I can take folks' contact information and then direct them to you if that's okay.
Okay, sounds good.
Okay, perfect. Thank you, Jennifer. HMIS team, Paige, I know you have another section. Are you guys able to stay a little late?
Yes, I am available.
Okay, and I see folks typing in the chat that they can stay. Awesome. So for the rest of you guys, if you guys want to stay, we'd love to have you. I think we'll definitely wrap up by 11 a.m., hopefully sooner than that, but just want to give the HMIS team time to give their full presentation because they prepared this content, and then for us to talk about the other things. And then we are recording this too, so we'll try to post this afterwards as well, but okay, with that, I'm not going to take up any more time trying to problem solve. I'm now going to turn it over to our lovely HMIS team, and they're going to talk to us about how we track and use data in Detroit.
Thank you, Katie. Good morning, everyone. My name is Kiana Harrison. I am a HMIS system administrator with HAND, and I am presenting today with the lovely Lauren Bianchi. Okay.
Hello, I'm Lauren Bianchi from HAND. I am a HMIS system administrator and data analyst.
Right. The Homeless Management Information Systems, that is the acronym of HMIS. Next slide, please. What is HMIS? So ultimately, HMIS is an electronic data collection system. It stores all of the person level information about clients who access our homeless services in the Detroit CoC. HMIS first came on the scene in the 1990s as a response to a mandate by Congress requiring states to collect data on homelessness as a condition of receiving the federal funding in their communities. It is currently administered by the U.S. Department of HUD through the SNAPS office, who oversees what we do in HMIS. Next slide. Just wanted to cover for Michigan and folks on this call, like the software that we actually use. So Michigan's HMIS is often referred to as Michigan Statewide HMIS. So you may see that acronym around, and that is just letting you know that we are a state implementation. So all of the individuals in the state that are doing HMIS are all using the same software. That software's name is Community Services. That is a new name. It has formerly been called and known as Service Point. And the vendor that we currently have is Well Sky. And we just wanted to drop the URL in there so you know exactly how to get to HMIS. Next slide, please. Why is HMIS important? So it kind of goes back a little bit forward from the 90s. In 2009, the HEARTH Act was enacted into law, and it implemented a requirement that all communities have a HMIS system with the capacity to collect unduplicated counts of individuals and families experiencing homelessness. So this was across the country that this requirement came out, and the HMIS system you use may be different across the country, but you had to have an HMIS. It also codified into law certain specific data collection requirements. It also provided us with a guidebook, data and technical standards. The current version is updated as early as June 2020. We have not had an update since then, likely due to the pandemic, but they typically update that document annually or every other year. The Act also requires that HUD ensures operation and consistent participation by recipients and sub-recipients in the system. Next slide. All right, so each CoC must have a HMIS. HUD actually assesses and scores progress in the annual CoC application based on a lot of data that is reported in HMIS. Some of the examples of our critical regulatory reporting that you may hear about or have heard of are the longitudinal system analysis, also called LSA, the system performance measures, and the point in time count and housing inventory count. Implementation of HMIS at the local level supports agencies and system-wide reporting, and it also helps with coordination around service planning. Next slide. As Jennifer and others have presented today, I kind of wanted to bring that full circle. A lot of the tracking of the programs that you've heard about is tracked in HMIS and required. It helps us to identify folks that are literally homeless or at risk of homelessness, and it is used by CoC, Emergency Solution Grant, SSBF, which is the veteran program, HOPWA, RIMUS, and PATH. These are all pretty big giant acronyms, but these are HUD-funded projects that require the use of HMIS. We also have to monitor ongoing data completeness and data quality and report back to HUD. Next slide, please. So just wanted to bring you kind of up to speed around HAND's role locally in relationship to HMIS. So HAND is considered an independent jurisdiction. We're the CoC lead agency as presented earlier in the slides, and we are the HMIS lead for the Detroit CoC. One of the roles as the HMIS lead is that we have to plan, develop plans, policies, and procedures around how HMIS is implemented in our continuum. Part of that, a few things that we have to ensure is that there are participation agreements and MOUs with every single contributing organization. We also have to make sure user agreements are given and up to date for every single user that is accessing the system, as well as just manage the system on a day-to-day basis, as well as provide technical support and training. Those are a few of our duties that we do as the HMIS lead. Next slide. I want to talk a little bit about coverage. Right now in the Detroit CoC, we have 37 agencies, 142 projects, and 311 individual end users entering data into HMIS. About 90% of our projects that enter data in HMIS are required to, and we have about 10% of the projects that are just doing it voluntarily. Next slide. Just a recap of some of the benefits, and just to give you kind of a perspective around how it is beneficial to clients, to service providers, as well as policymakers. For an individual client, it can help to decrease the duplication done related to the intakes and assessments for services as they're coming in trying to get assistance. It helps to coordinate case management and improve access to mainstream benefits. For service providers, some of the benefits is just the ability to track client outcomes and measure the success of your projects, measures effectiveness of services and identifies any gaps in services. It also helps to promote collaboration with other providers. Here in Detroit, we are an open sharing system. So the providers share with each other the data that they're entering into the system. It also allows providers to prepare for reports for their funders, their boards, and stakeholders. And as a policymaker and stakeholder, it allows access to system-wide data that a lot of these individuals request and require. It also helps to improve their knowledge about the services and gaps as we seek funding for supporting our community. And it also helps to enhance community planning and, of course, fields policy decisions. Next slide. And just giving you kind of a different layout of how some of the data is used. HMIS has been used to inform national policy. Again, it is required by these entities here, ESG, whether it's city-funded emergency solutions or state-funded emergency solutions. Several of our veteran projects use HMIS, as well as HOPWA, PATH, and RIMUS, which are respectively HIV/AIDS programs, outreach, mental health outreach programs, and youth projects. It helps enhance case management and, again, informs local planning. I'm going to turn over the presentation to Lauren, who's going to walk through how to get into HMIS and also show some examples of the actual data that's coming out of HMIS. Lauren?
Thank you, Kiana. So now we've discussed what HMI is, why it's important, who we are at hand, and what our role is in relation to HMIS. We'll talk about how to get into HMIS and like Kiana said, some snapshots and other information. So HAND's HMIS website is the first step to begin the onboarding process. Not only do we have information about our system and access there, but we also have information to CoC reports and other helpful HMIS program related materials. This is also where our HMIS help desk lives, if you will. And within that HMIS site is our help desk, and that's the portal for requesting access to HMIS. And it is kind of a go-to for other HMIS related technical assistance and more. Next slide, please. So for onboarding, for new agencies, the onboarding process begins within that help desk I was just talking about. Our help desk is the one-stop shop for getting your agencies into the system. All new agencies that sign up for HMIS access must become part of our Detroit CoC sharing agreement to participate. However, there are some special circumstances where an agency can opt out of that external sharing, and that process will be addressed on an as-needed basis. For our existing programs, all updates, changes, and questions about programs for end users and data quality can also be addressed within that help desk. And then for new and existing programs like the HMIS help desk on HAND's website provides a portal for a multitude of troubleshooting issues, report information, and more. Next slide, please. So general overview for new agency onboarding. We have a graphic here, and these links are accessible when the slides are sent out. So ultimately, the first step is to go onto our website for our HMIS page and access our new agency application form. Once that's completed, you'll submit that form via our HAND help desk for HMIS or directly to our HMIS.info@handdetroit.org email. Next up, you'll review our fee schedule for HMIS, which is important to determine your agency's licensing needs. And then if you're accepted into the system, you can access the HMIS help desk to add a new program into HMIS. Next slide, please. For end users and licenses, once on board, the users will have to complete trainings on the HMIS Learning Center. Once they're registered within that website, we recommend reviewing the HMIS training grid on our website to ensure all needed trainings are completed. And once those certificates are downloaded, they can be sent in through our lovely help desk to add end users and get their HMIS licenses assigned. So in relation to other administrative requirements for HMIS, it's extremely important to note that onboarding and entering data are just the first steps of participating in HMIS. There are additional admin requirements needed as well. So ongoing data quality is super important for regulatory reporting, kind of like Kiana was speaking on earlier. It's a shared system so that data quality ties into everyone. There's also mandatory meetings and webinars, participation in the annual PIT and HIC counts, as well as additional program-specific data reporting at various intervals per funding sources. So HMIS is an allowable cost through several of the funding sources we've discussed throughout our presentation. We do encourage agencies to plan for staffing and management in relation to HMIS activities, and we recommend considering at a minimum direct data entry staff and HMIS agency administration staff. We have found that data analysis staff can also be beneficial for overall data quality. The staff that are usually doing the data input are, your case managers, agency administrators, specific data entry staff or supervisors. And our HMIS policies and procedures require a continuous quality improvement component that will likely include a combination of HMIS and compliance staff from your agency. Which brings us to how much time is actually spent within HMIS. So HAND did a poll for some existing agencies, and we discovered that emergency shelter providers are typically spending 32 minutes per individual, 90 minutes for a family, and roughly 3 hours a month on data cleanup, where other providers for rapid rehousing, permanent supportive housing, street outreach, and prevention reported spending roughly 56 minutes per individual, 90 minutes per family, and then a good 7 hours a month for data cleanup. So in the next few slides here, we'll quickly highlight what comes out of HMIS. So these data reports that we're sharing are snapshots, but the full reports and visualizations are of course accessible on our HAND website under the resources link. So we'll be talking about the annual report, our SPM and HIC visualizations, and our APR visualizations. So first up, we have a snapshot of our annual State of Homelessness report for the Detroit Continuum of Care. And this features various statistics and trends that we've noticed throughout the year in relation to our folks experiencing homelessness. Next up, we have some snapshots from our system performance measures and housing inventory count data. And then on the next slide, we have APR data visualizations focusing on rapid rehousing programming. Here are some extremely helpful HMIS resources from HUD, as well as a link to our plugged in HMIS help desk. And last but not least, we have our HAND HMIS team. If you have any questions or concerns in relation to HMIS, you can always reach out to any of us and we'll make sure you're taken care of. So I don't want to take up too much time here, but thank you for listening to our spiel on HMIS.
You guys so much. That was great information. So now we're going to move into the last segment of our webinar today. I'm going to turn it back over to Paige, and Paige is going to talk to us about how you can get involved with the Detroit CoC.
Yes, and I promise I'm wrapping up really, really soon. So how to get involved. There are a number of opportunities for partnership to work with our CoC. You could connect your clients to our system through the coordinated entry. Let them know if you have nowhere safe to stay, contact the CAM. Get in touch with us if they need somewhere. Join our CoC general membership or board and or participate in the meetings. I'll speak more to that in a second. You can participate in some of our committees. We have a number of committees that work on the integral and internal pieces of our system, and so that is open as well. You can stay informed by receiving our COCs and CAMS newsletters. You can volunteer or donate. You can advocate, which is always great. You can become a provider. Lauren talked about that as well. And for veterans, you can contact the William R. Browning, Chief of Volunteer and Community Relations at the Detroit Veteran Affairs Medical Center. The phone number is here. These slides are going to be sent out to you, so you don't have to jot that down. Next slide, please. All right, so how to join general membership. So general membership, first you need to attend one general membership meeting. The meetings happen on the third Tuesday of every other month. Next meeting will be March 16th, next Tuesday at 1:30. So you can register for the link, okay? This right there is going to be sent out. Looks like Katie's going to also put it in the chat. Thanks, Katie. All right, and also the step 2 is going to be that you need to complete the online application as well. Next slide, please. All right, so what to tell people in need. So if an individual or family does not have a safe place to stay for the night, please have them call CAM. CAM is going to be the place, and we're going to be the help that they need in order to helping them find a safe place for the night. I will say this has always been our disclaimer because we are limited on the resources, but we definitely try to make sure that everyone has somewhere safe to stay. So we cannot guarantee that they're going to receive a shelter referral that day, but what we can guarantee is that we'll help them find somewhere safe. So that may be redirecting them to a family member house or something of that nature. Okay, the housing assistance is not guaranteed as well, but again, we're always going to do our best. Limitations and challenges. I just spoke of this. There are insufficient shelter and housing resources for everyone that's in need. And also funding does limit the ways that we can engage with our homeless households and addressing the homelessness. Kind of talking about the couch surfing idea or situation, or people who are in need of the permanent supportive housing, but they don't technically need shelter. And so our funding is limited in how we can address needs of individuals as well. All right, so the COC newsletter, you can subscribe at the bottom of any HAM webpage. So that is thehandetroit.org. You will receive updates about the COC, relevant federal and state updates, meeting notices and materials, funding opportunities, helpful resources and trainings, and also job openings as well. All right, for the CAM newsletter, you can subscribe by clicking this link. Katie's going to put it in the chat box. Thanks, Katie. Updates about the CAM policies are what you're going to hear about. Processes and operations. You're going to receive data on client access and referrals, helpful resources about training opportunities. We also put our job postings there as well, so check that out as well. I think we have an opening, so little shout out there. And then for veteran information, anyone can go to the Detroit, va.gov for any information on the VHA in Detroit, the veteran homelessness. I don't know what that is, but sorry, Katie, VHA. You could go there for any information. And then as a community, we are still continuing to put out our COVID-19 information. We do have a specific newsletter that goes out. Katie's putting out the link. What you will receive is our situation reports, which is just like a really informative report about everything that we're working on through that particular time frame. That's going to include the relevant data, the system changes, and any actions needed. Notice of important COVID-19 related changes as well, any operational changes. Changes. So register for the biweekly webinars by clicking this link. Katie's getting that out, and then access any past webinar material through the link that she's sending out as well. Again, a copy of this presentation will be sent to your mailboxes shortly. All right, next slide. The next one is the Friday the 19th. So next week is a busy, busy week for us. All right, so that concludes our presentation. I know we had an opportunity to answer some questions throughout the presentation. Are there any more lingering questions, anything we need to clarify on, expound on, anything at all? No, we did that good of a job. Well,
A minute or two just in case, maybe.
yeah, absolutely. And I will also say, Katie, our information gets sent out with the slides as well, right? If not,
That's a good idea. We can send out everyone's email address.
cool. So let's do that as well. So if you guys have any specific, questions relevant to our specific departments, then definitely reach out to us. I know we'll be happy to get you the information that you need. And I don't want to keep you, if you don't want to be here, you got something else to do. So you are more than welcome to log off. If not, and if you want to stay on and ask any questions, feel free. Thank you, everyone. I appreciate it.
Thank you.
Thank you so much. Alrighty, not seeing any questions come in. I think I'm gonna call it for us. So thank you guys again, truly thank you for being here. Thank you for all your great questions. Hopefully this won't be the end of our engagement together. Always feel free to reach out and continue to talk to us if you have questions or ways you want to partner or any needs, and we will do our best to work with you to address those. So thank you guys so much and have a wonderful rest of your day.